And although I have arbitrarily separated the lectures into diagnosis, medical treatment, and surgical treatment, of course they overlap. And so if you are diagnosed with trigeminal neuralgia, your first safe step would be to see a neurologist. And the next lecture is going to be provided by one of our neurologists, Dr. Gordon Robinson, who is the leading expert in headaches in the province of British Columbia and a clinical professor of neurology here at the University of British Columbia and a personal friend of mine. And he has kindly agreed to give us a lay lecture with a focus on the potential medical treatments for trigeminal neuralgia. Dr. Robinson.
Thank you, Chris. I thank you for your invitation and congratulations for including people who suffer from trigeminal neuralgia. In my experience over the years, particularly in migraine, it's an excellent addition to any form, and patients appreciate it tremendously. So congratulations. I'm not sure whether I'm the token neurologist or the token local presenter, but anyway, my task really is to give you an overview of the medical management of trigeminal neuralgia. And like all experts, we have slides. Okay. Disclaimers. There are a couple of potential treatments that I'll be discussing, and I sit on the advisory board for a couple of those companies, namely Allergan when I discuss onabotulinum toxin A, and Novartis when I discuss aranimab as a future treatment. And a way I've divided this up is...
Sorry, we're not seeing your slides.
Oh. What are you seeing?
Just you. You'll need to share it in the Zoom if you go to share screen in Zoom.
Did that, I thought.
There it is.
There it is. Happier now?
Great, thank you. Perfect.
That's that little step I always forget. Anyway, I've divided this up into basically talking about the pharmacological treatments, and then prompted by questions that were provided to me, I've added a section on nutraceuticals, which have become increasingly popular, particularly since pharmacological treatment in TN is a challenge for patients to get efficacy and cope with side effects, and a challenge for physicians to treat the patients effectively. And then I thought you would be interested in future developments, what's potentially coming in the pipeline. And this is relatively new. And despite treatments for TN being relatively static for almost 60 years, I think there's good reason to be hopeful that science is going to maybe catch up and help what is an incredibly difficult pain disorder. The evidence base, the way we function in medicine, exposing treatments to large randomized clinical trials in order to make some scientific judgments, is really poor in all of the treatments in TN, or it's just non-existent, and we get case studies, anecdotal reports, expert consensus, which is all we have, and but hopefully this will change with the newer treatments. It's challenging, as I mentioned. Not everybody responds to the medications that we have at the present time. Adverse events are common, and this was alluded to in questions with the previous presenter. And one of the problems, people that do respond, is that there's often a lack of response with long-term use. Now, whether this is a failure of the drug or whether it's a progression of the disorder is not known. And although we always prefer a single agent in treating a disorder, in TN, the single agents are often suboptimal, and polypharmacy, polytherapy is often required, which adds more burden in the adverse event category. The first-line treatments have not changed in decades, and carbamazepine and oxcarbamazepine are anticonvulsant medications acting on sodium channels, and the evolving pathophysiology of TN suggests that that is why these drugs work, stabilizing membranes as they do in epilepsy. They do have substantial side effects. There's a fair incidence of allergy, and if you're allergic to one, you're probably going to be allergic to the other. Oxcarbazepine has a somewhat better side effect profile. Both drugs need to be taken at least twice and preferably 3 times a day. So although they are the best we currently have in the way of efficacy, there's problems with them, both for tolerance and not helping all patients. The second-line treatments are used either if the first-line drugs don't work or they're poorly tolerated, or they may be add-ons to carbamazepine. And these include lamotrigine, another anti-epileptic, gabapentin, pregabalin, and baclofen. Again, they all have their unique side effect profile. Many of those do have problems with sedation. And again, the risk benefit when it comes to adverse events may be difficult for many patients. An evolving treatment has been the use of onabotulinum toxin A, trade name Botox, obviously. And much of my experience these days in TN is related to referral pattern. I see TN patients on referral from Dr. Honey when he either doesn't think they have TN, he's usually right, or whether he has a patient who doesn't want to do surgery and wants to embark upon other medical treatments. And for the most part, they've seen other neurologists and tried most of these things. And my other referral pattern comes from our multiple sclerosis clinic, and I've seen quite a few people with secondary TN. And in these refractory groups, I have used onabotulinum toxin A probably for the last 15 years with quite good efficacy and virtually no adverse events, aside from the occasional transient facial muscle weakness. It's totally well tolerated, and very, very small doses injected subdermally following the pain where the TN is can be quite helpful, and the effectiveness can last for up to 12 weeks. There are others, and I'm not sure we call them third line or where they fit in. Sumatriptan, which is a drug that I've been familiar with since it was introduced in 1992, is a mainstay and was the first acute medication for migraine. And given its mechanism of action, it has been trialed in TN as a subcutaneous injection, as an oral or intranasal medication. And although larger trials are needed, it has been showing some promise and managed to have an article in the most recent Journal of Headache, which is the preeminent journal for headache in North America, and encouraging further study of sumatriptan, which is generally well tolerated. valproate, phenytoin, topiramate, levetiracetam. These again are anticonvulsant medications leaning on the presumed pathophysiology shared by seizure disorders and TN. And again, they have their idiosyncrasies when it comes to adverse events. But for some people, these can be useful add-ons usually to a first-line drug. This highlights the commonly used drugs in the first list and the starting doses and the titration, how the drugs are gradually elevated in dose over time. Some of these are a bit aggressive. If I had TN, I'd want treatment right now. So it's sometimes difficult to convince people that you need to escalate slowly, which usually results in some tolerance of side effects until you get up to a dose range that's acceptable for improvement. If you start at too high a dose and there's serious adverse events, it's really hard to go back to that drug in a given patient. So the admonishment of start low and go slow, which we use in migraine, also should be applied to the drug treatment of TN. These are the dose ranges and the frequency of dosing, which for most of them, other than botulinum toxin A, are 2 to 3 times a day. This can be difficult to manage with compliance. It's very hard to remember to take drugs that often. Nutraceuticals, limited evidence base again. A lot of the vitamins and minerals, as well as the cannabinoids, rely on an animal model for neuropathic pain. And since TN is a neuropathic pain generated from the sensory nervous system, if there's efficacy in this mouse model, then the use of the nutraceuticals are introduced and may be adjunctive therapy to the pharmaceuticals that I just discussed or stand alone. There are virtually no properly done trials in humans, and humans are not mice. And so extrapolating from the animal model is not clearly accurate. The supplements that have been suggested, I guess is the best word, and these have been trialed in the animal model, include zinc, magnesium, vitamin D, vitamin B9, vitamin B12, curcumin, and St. John's wort. Again, there are no randomized clinical trials, anecdotal experience, maybe some case studies, but no evidence base here. For the most part, these are safe to try, particularly at these dose ranges. Toxicities are possible even in so-called naturally occurring compounds. So some care needs to be taken when these are trialed. Cannabinoids, I usually put medical marijuana in quotation marks because it's a difficult topic. Everybody knows about it. Everybody, some people tout THC or CBD or a combination thereof of a panacea for almost anything that ails us. There's an incredible lack of properly done medical trials on any disorder when it comes to cannabinoids, but theoretically they should act on neuropathic pain. But most of the experience is anecdotal. Most of that experience is using CBD You don't get high, but your pain gets better would be the best outcome. It's generally safe. There have been reports of liver toxicity with high dose CBD. One question was, with better THC or CBD, or is it a combination? How much of one, how much of another? That's totally beyond our knowledge base at the present time. Although because of the euphoric effects of THC, it's CBD that seems to get most of the attention when it comes to using cannabinoids for neuropathic pain, for TN, and for most other pain disorders. The future, as Talis would say, perhaps the future is friendly. Arenumab is a CGRP monoclonal antibody that we have been using in migraine over the last 3 years in Canada. This is administered as a monthly subcutaneous injection, self-administered because it is so safe and well tolerated. It inhibits the receptor for calcitonin gene-related peptide, which is an important neurotransmitter in migraine. It's also potentially a transmitter in neuropathic pain and in TN. And there is currently a phase 3 trial being undertaken in North America looking at arenumab in the treatment of TN. Otherwise, there's been some case reports that it may be helpful in TN. Atogepant is again a CGRP inhibitor, but this is an oral medication. It is taken as a single daily dose. It's been available for migraine prevention in the United States for a short time. We expect to get it in Canada within the next few months. There is a phase 3 trial underway looking at atogepant in TN. It looks very good when it comes to inhibiting migraine and extremely well tolerated. Both arenumab and atogepant, the main adverse event, and it's around 10%, is constipation. Other things don't appear to occur, and these are really well tolerated therapeutic agents. There's a variation of carbamazepine, eslicarbamazepine, which is a so-called third generation anti-epileptic drug, again, acting on sodium channels. It may have fewer adverse events than the other available ones. And one of its attributes is that it's got a long duration of action and need be taken only once a day. Vixotrigine has been in development for some time now. And this is a selective sodium channel blocker. It's in phase 2 and 3 trials at the present time. The phase 2 trial that was reported wasn't stunning when it came to efficacy in TN. Primary endpoints were not met, but some of the secondary ones are. But it's possible that this could be available within the next year or two and could be an add-on to current treatment. Basmaglurant is a glutamate receptor inhibitor and is being trialed also phase 2 and 3 in TN and is showing promising results, but is farther back in the pipeline than Vixotrigine. So the first two are available now or soon to be available. Eslicarbamazepine is soon to be available. Vixotrigine, basmaglurate, next couple of years. And an interesting one is nasal carbon dioxide is currently under investigation. And it's intriguing. The trial has patients administer through a nasal prong carbon dioxide in the nostril on the side of their TN. and they will breathe this for about 60 minutes and do it either once a day or a few times a day. And the early trials suggest that this will reduce the frequency and severity of TN, which is got a novel approach, to say the least. And the reason you don't want to breathe it in both nostrils is that you get carbon dioxide poisoning. So one nostril is perfectly safe. To put all of this in perspective, and I guess lead on to the other portion, the neurosurgical portion, the idiopathic, classical, and secondary TNs, the medical treatments are basically the same for all of these groups. In secondary, obviously, if there is an underlying cause, that is dealt with first. But if the pain disorder persists and it has the characteristics of TN, then the use of the anticonvulsant drugs, the pain modulating drugs, the botulinum toxin type A, all can be employed. And nobody knows whether the medical treatment works better in idiopathic versus classical versus secondary. Again, it's all anecdotal and doesn't matter anyway, in fact, because we treat patients as best we can using the tools that we have when it comes to medical management. When medical management fails, certainly in the classical group, I defer to my neurosurgical colleagues for the various procedures. Microvascular decompression has certainly gained prominence as the first-line surgical treatment for classical TN. And then, as alluded to earlier in the previous presentation, there are other invasive treatments, as listed in the slide, that can be used in either idiopathic, classical, or secondary TN. So I wanted to give lots of time for questions, and I have. So let's see, what do we got? Is research being done on causes of TG? I guess that's TN. Research seems to be focused on treatment versus cause. Well, most of the thrust is in classical TN, showing morphological changes at the root entry zone of the trigeminal nerve that appear to result in these bursts or discharges of electrical activity that result in the pain. And much of the research is in looking at MRI and looking at surgical specimens from decompression. Okay, well, that's nice. That's disappointing to hear that the trial for Runimab, my previous colleague has told us that she was involved in the trial. It hasn't been published yet, but the single dose didn't work. So that's coming in Lancet Neurology in a couple of months. So unfortunately, that takes that off the table. And sadly, it may also take itagipan off the table, since the mechanism of action of both of those agents acting on CGRP is the same. Do the medications always eventually lose efficacy, or are there cases where efficacy is continuous? I don't know that anyone knows the answer to that. I do have patients who have been maintained on medical treatment, for many years, for a decade or more. But when I think about my experience in talking to other headache specialists, the thing we often see is the kind of honeymoon period at the beginning. during the relapsing remitting phase where the medications seem to work really well. Do they work really well, or do things go into remission? When you treat something like that, the last thing you use gets credit for it. But I think it's a much easier disorder to treat it first medically. And I suspect that the TN changes over time rather than loss of the effectiveness. It just becomes harder to treat medically. The drugs are the same. The drugs don't lose efficacy in other disorders such as epilepsy that does have parallels in the pathophysiology. So my own view is that TN probably does progress, and we have a much harder difficulty treating it. Next question, I have bilateral TN1 and TN2. Which course of treatment is best, and are treatments the same for both? Thanks. Yeah, the quick answer is the treatments are the same for both. When it comes to TN2 with the persisting pain, I'd probably add a tricyclic or a SNRI like duloxetine to see if there was some efficacy. The anticonvulsants, the carbamazepine group, seems to work best on fleeting pains, the electric shock-like pains. And we see that in other neuropathic pain patients, where if the majority of their discomfort is that shock-like, tick-like pain, the carbamazepine tends to work better than the tricyclics like amitriptyline or nortriptyline. And when we see patients who have a constant burning, searing pain that's neuropathic, the tricyclics and the SNRIs are probably the treatment of choice. And in the carbamazepine group, doesn't seem to work as well. But when you've got both, the treatments are probably the same, except for that little add-on potentially of a trial of a tricyclic. My physician, neurologist, started me on Lyrica, which is pregabalin. I just started 2 weeks ago. Is this okay? I have classic old TN diagnosed with MRI. Yeah, it's not generally first line. Carbamazepine tends to be the first drug that we try. But I'm glad you've got the physician's attention, and he or she is attempting to help you. I would suggest referral to a neurologist who has some expertise in TN. It's not the easiest disorder to treat, as most of you will attest to. I've been told that I have referred pain caused by TN with little explanation as to how that happens. Can you offer insight into that? Not sure how to answer that question. Referred pain caused by TN. Well, TN is within the territory of usually the second and third divisions of the trigeminal nerve. I suppose there can be some referred pain to the neck, and there's been some use of occipital nerve block in patients with TN, possibly with some efficacy. Perhaps that's what's being described, because I don't really know where the referred pain is going to, but I don't think you would have TN not involving your trigeminal nerve without that diagnosis. What are the types of medication could be used other than carbamazepine or lamotrigine, as it doesn't work for Asian descent patients? I think I covered that. There's a whole host of them. Although in my experience, if you have a patient that doesn't respond to one of the carbamazepines, it's going to be a challenge, and particularly later on in the disorder. But it's a matter, it's trial and error of either adding on or going from one agent to the other in the list that I talked about in an attempt to find something that is both tolerable and meaningful in the way of pain response. Our repeat MRI suggested every few years to assess changes. I would probably defer that to one of my surgical colleagues, particularly Dr. Honey. I suspect not necessary. I assume this is in someone that has had MRI and is negative but not had MVD. I don't think you need to have sequential MRIs. I already had epilepsy when I got TN. Are they related? Not to my knowledge. They're separate disorders. I'm not aware that there's an increased prevalence of epilepsy in patients with TN. Is pharmacological treatment recommended for patients who can tolerate the occasional pain, or is it necessary for preventative measures of decline? My sibling died of SUDEP while not taking medications, so the current is if medication is necessary. You know, there's no evidence that treating TN with the medications is going to change the natural history of the TN. I think that treatment is introduced when patients have had a good discussion and they're able to decide whether they wish to take the medications given the level of discomfort they have with TN. I've not seen anybody who doesn't want treatment because TN tends to be pretty horrible in almost everybody I've ever seen. Is one of the side effects in carbamazepine dizziness and fogginess? Can this result in onset dementia? Yeah, dizziness and mental fogginess, even double vision, are relatively common side effects of carbamazepine. There is no evidence whatsoever that carbamazepine or any of the other treatments listed in TN or TN itself increases the risk of developing dementia. How many Canadians do you estimate have TN? I'd have to do the math. I think it's something like 0.05 per 100,000. It is a rare disorder, which is probably the major reason that there's so little large-scale research being done in TN. Most of the new medications come out of the pharmaceutical industry. It's extraordinarily expensive to mount a clinical trial for a preventive drug in the migraine population, and it wouldn't be much different in TN. It will cost you in excess of $600 million, and you start without knowing whether you're going to have anything to bring to market. And so universities aren't equipped to do these sorts of things, and pharmaceutical companies make decisions based on the market. And almost an orphan disease like TN has such a small number of people that it doesn't drive any market for the major pharmaceutical companies. And so much of the research is done in drugs that have been developed for other disorders and look like they may have some rationale for TN. Then they jump to the phase 3 trials for the disorder. Okay.